Hello, everyone. Welcome back. Today we have with us Dr. Chetan Trivedi. Welcome, Dr. Chetan.
Thank you.
Thank you for taking the time to be with us. Dr. Chetan is the director at the Neha Children's Hospital at Ahmedabad. He is a consultant pediatrician with special interest in vaccinology, infectious diseases, and of course, general pediatrics. So, once more, Dr. Chetan, welcome and thank you for taking the time out. Today, we shall be discussing about one of the diseases which is very I would say common these days, traveling around the country because of the weather, etc. That is influenza. So let's talk about the challenges that we face in influenza, and then of course we can't complete without talking about the vaccine. So if you can, start by telling us about the epidemiology and the seasonality of this viral infection, influenza, Dr. Chetan.
Yeah, thank you, Dr. Sumitha, for this wonderful opportunity to discuss academics and particularly a topic which is really a hot topic because nowadays everywhere it is only one virus which is growing, rather overgrowing, it's influenza. And we were expecting a dengue, but I think this time it is less dengue, more influenza. And it is you can have only one virus in circulation, not many. So this time it is influenza. That's it's worth discussing this particular influenza. And you know that with influenza nowadays it is hitting the main headline of this all newspapers nowadays, because initially I thought it is only in Ahmedabad, only in Gujarat, but I think all over country we have influenza epidemic. So this influenza globally, if you say, almost more than 1 billion cases of seasonal influenza occur annually, and out of that 3 to 5 million they can be severe influenza, and almost 3 to 6 lakh deaths occur because of influenza globally. Now this is a global incidence, and we know that this particular influenza particularly affects almost all age groups, but it is more important when we talk about young children, old adults, or those who are having some comorbidity or a pregnant woman. So that's why this particular group of the people who get affected very badly. Now, influenza, when we talk about the spread, we know it is a airborne infection, so respiratory droplets and aerosol, the way it transmits. Now, seasonality is different thing rather than the epidemiology, right? So the epidemiology may be just saying what is the rate of occurrence of this disease, but seasonality is very important because flu is a seasonal, is known to cause seasonal outbreak as well as annual epidemics, right? So, and of course, pandemic, we know of influenza, we know by just 2009 pandemic only. So when we talk about seasonality, globally, we have two seasonalities. One, matlab, northern hemisphere and southern hemisphere. So people, they believe that when it's talking about northern hemisphere, it's autumn, winter, that is December to March, that is a particular season for flu. When you talk about southern hemisphere, it is May to September. That is traditionally been, opposite to both the hemisphere. But this is true for temperate countries. But when we talk about tropic or subtropic, where India stays, and here the influenza occurs all throughout the year, what we particularly find in our country is, so yeah, we see the influenza all across, all throughout the year, but there are some seasonal peaks. So depending upon which part of the country we are. So if you are talking about northern part of the country, we see more winter peaks. When you talk about rest of the India, we see more of the monsoon and pre-monsoon peak. And Tamil Nadu is a special category where the rain is different, the timing. That's why they have different timing of the flu. So we can say in India, we have no specific seasonality. We behave like southern as well as northern hemisphere, but we have seasonal peaks also. So that is typical of the India.
Thank you, Dr. Chetan, for describing in such great detail how this seasonality of this virus has been noted over the past several years, and I'm sure it will continue to be there. And we do understand that this is a virus which is slightly different from the other viruses. It undergoes changes. So, can you please explain what we mean by antigenic shifts and antigenic drifts, especially related to the influenza virus?
So, first of all, we should be knowing that influenza is different types. Type A, B, and C. These three we understand properly. D is there, but it is not for us. It is for animals. A and B we see quite frequently. C is a milder disease, so forget about C. Now there is A and B. There is a difference because zero that A is having different surface protein like HA and NA, hemagglutinin and neuraminidase, and different because of different combination. They have subtypes of A. So maybe suppose H1N1, H3N2. So these are the different subtypes of influenza A. While influenza B, they don't have subtype, but they have lineages, say Yamagata and Victoria lineage. So this is two influenza A and B. These two are the main types. Now, these particular influenza is having a antigenic content, right? It is a single-stranded RNA virus with segmented nuclei. So what happens? There is some genetic changes which occurs when it is occurring small point mutations. So the virus will just change the face of it. So that is just drift, a slight change, but it is not the same virus which we were having in circulation last year. So the small variation, small change in this point mutation about this virus surface proteins like Na and Ha, that is called antigenic drift. Now this is the main basis on which we have to give annual vaccination. Because if we have given vaccination last year, but that virus has slightly changed, so whatever antibodies we had, that will not be protecting against this changed, drifted virus. And that's why we just make a different combination of the serotypes, and then we give the seed lot and we prepare vaccine. While when we talk about the shift is a major thing where you know that influenza A particularly is only known for shift, because once there is shift, it is totally new virus is coming out, because we have different reservoir, like we have animal reservoir, birds are, pigs are there, and humans. While influenza B is only in humans, so it is not known to cause antigenic shift. But influenza A, when it two different viruses attack the one host, and there is some exchange of genetic material, and that makes a different virus. So totally new or novel virus comes against which we don't have any experience, we don't have any exposure. So that's why that really creates a panic, and this a pandemic is occurring. So this is antigenic shift. It is sudden and major change, maybe because of exchange of the material as well as the reassortment, genetic reassortment. So new virus comes, and that really kills the people, and that's what we had in 2009, and that was pandemic. And that is called shift and drift. So there's some difference. We don't have answer to shift. We have answer to drift.
Dr. Chetan, now you have very, very, nicely explained it. So small changes, small alterations, it's a drift. And major changes, recombinations, a new virus coming out, that is a shift. So we have to actually watch out for both of them. And as you mentioned, yes, we do need the annual influenza vaccine. So coming to the, disease as such, we know it starts with fever, then maybe, malaise, etc. So any definite pointers or red flags which can tell us probably upfront that this could be an influenza attack?
I think, actually speaking, there's nothing like red flags. But if you are in proper season, you can suspect it very easily. Because when you say influenza, it is a flu. It's a viral infection. It can come with fever. It can come with headache. It can come with a body ache. It can come with running nose. It can come with diarrhea, vomiting, so many things. Now, whether to tell it is influenza, it is only when you have a season we just suspect it. And you know that the milder things like fever, low grade, there is sore throat and some body ache, headache. So there we suspect some viral infection. But when you are in proper season, we suspect is influenza. Of course, if it is having severe high grade fever, because this particularly influenza virus, what we are seeing nowadays trend is sudden onset, acute onset of fever, and that goes 100 to 100 to 104. And there is severe sore throat. And when you examine the throat, nothing is there. So throat pain is there, but there is nothing like the redness or that or anything you find. Severe body ache, headache is there, and most importantly, patient become fatigued. At the same time, what we have observed in our children, they come with a diarrhea vomiting, and that is many times misleading us. That we think, oh, it is diarrhea vomiting, nothing respiratory. So we suspect only when there is a viral catarrh or some respiratory cold and cough, we suspect. No, we have to suspect in this. So these are the situations when you have to suspect it. So once you suspect it, and then you have to investigate or rather take a clinical decision whether to treat it or investigate or what to do. But most importantly, when you have a complicated things, maybe suppose your fever is very high grade, it is not coming down, patient is delirium, with not having anything orally, with not passing urine, maybe having breathlessness, hypoxia. So these are the condition. It is severe sort of flu like illnesses. So there we should be very careful and managing a bit rapidly diagnosis and management fast.
Thank you for mentioning, the red flags. I think all of us, because we do see these common presentations, I think the red flags have to be definitely watched out for and managed on an urgent basis. So, moving ahead, can you very briefly tell us the diagnostics which will help us to arrive at the diagnosis here?
So whenever you talk about diagnosis, we know we should be suspecting that case of influenza. That I said that acute sudden illness, there is fever, cold, cough, myalgia, headache, and there is epidemiological compulsion or rather epidemiological exposure. There are a history of people having in the family or in the school. There are so many kids are getting it affected. There you suspect. Once you suspect it, then you have to decide whether to go for investigation or not. Because what happens nowadays, we have already every third patient is having same symptoms, and many times we know this is definitely influenza. So in that point of time, you may decide to treat empirically, or you can go for investigation. Now there is some guidelines which has been given to us where to investigate. So in general, without going to details of the guidelines, when we suspect it is something like severe influenza, or there is some comorbidity, or there is high risk factors, or we expect this influenza to become worse, in that case, you may investigate and then treat it. And that particular condition, pregnant women and children. So we have that particular, all kids are our patients. So there we are almost falling into that category where we have to treat it as well as investigate. Now, how will you diagnose it once you have suspected it? I think only one thing which is available, which is routinely we are doing, is throat multiplex PCR, throat swab multiplex PCR. What we do, we have influenza PCR. So that gives us influenza A is present or B is there. A is there whether it is H1N1, H3N2, what. So that particular PCR gives us 100% diagnosis. There are other tests, by then we are not using it that frequently. So I am not aware of, but you are not using much. But this is what we are using for diagnosis.
Yes, thank you. So I think PCR is something which we may use as, based on the symptom and the presentation. So we do know, yes.
And one more thing I would like to add here. Yes, PCR is diagnostic, right? But when we suspect, and many a times, PCR is costly. So in routine practice, we cannot do it. Even OPD basis, because it is minimum in our setup, it is around 3,500 to 4,500 rupees. To just diagnose this thing is something more. Many times we end up in getting CBC CRP. And there you may get clue. See, it is not required to do CBC CRP, but if you have done it, if you have to interpret it, you may get some low counts. You have a low platelet. You have low to normal counts, low platelets, and CRP may be on lower side. So this will give you, yes, okay, this is a viral and looks like influenza. So this is, indirect way of looking at it, and then you may confirm or treat. True. You have to put everything together based on the epidemiology and, the local situation with the virus. Now, we do know that we have a specific antiviral for the flu, for the influenza virus. Now, could you please tell us about the role of this antiviral medication? Do we need to give it to every patient who comes to us with the symptoms, or what exactly? When is there a role for introducing the antivirals? So as of now, we are fortunate that we had a COVID epidemic, right? That was the worst part of our life. Similarly, pandemic when it occurs 2009, that was also very worst. But good thing is that we got the antiviral, which is oseltamivir, which is very good. It is very effective and works very nicely. So that's why we are enjoying the practice presently. Otherwise, it was hell of the time to have so many patients of influenza. So yes, we have antiviral, that is oseltamivir. There are other antivirals, like sanavir, that is I think given to be given inhaled, which is not available. Peramavir, that is IV, which is not available again. And there is baloxavir, that is also not available in our. There may be single dose. But what we are familiar with and using it very effectively is oseltamivir. Now, this oseltamivir is the antiviral. It is very useful because it is important for us to at least prevent the viral replication. You have to prevent the transfer of the disease. You have to prevent the complication, and you have to decrease the duration of the disease also. So all these aspects have been taken care of by this particularly oseltamivir. The tricky part of it is earlier you give within first 48 hours, then it will work the best. Now this is real problem in our routine day-to-day practice, because we at one point of time we don't want to overtreat, because otherwise it will be a unnecessary overuse or misuse of oseltamivir. Every patient with fever and throat will come, will start with oseltamivir. That is not a good thing, right? So we have to decide whom to treat, and when you treat it, we have some targets. So yes, we will treat those who are severe, those who are to be hospitalized, those who are in high risk, like our young kids, maybe a pregnant lady or age more than 65 years, or you have the comorbidity. These patients will definitely treat it proactively. And when you talk about 48 hours, you give it, start it within 48 hours, you get good response. That doesn't mean you don't start after 48 hours. So yeah, definitely it will help you to reduce the disease as well as the complication, even if you start after 48 hours. So oseltamivir is having a wonderful role in the treatment of influenza, and we must remember, or rather keep a dosage chart in front of us. Nowadays, we have fully by heart remembered it because you're using day in and day out. But we should be knowing there is a age-wise criteria. So, and the syrup which is having, which we are using more frequently, is 12 milligram per ml, right? And it is coming having 75 ml bottle. So according to that, and there's now smaller bottles are also available, 30 ml. So when you talk about say 5 to 15 kg, you have to give maybe 30 milligrams. So that will make 2.5 ml. So I remember 5 to 15 kg, 2.5 ml twice a day, 15 to 23 kg, 3.5 ml twice a day, 23 to 40 is 5 ml twice a day, and above 40, it is 6 ml twice a day. This is the dose we remember. Of course, in young children, it is maybe a 20, 15, 12 milligram, 20 milligram, 25 milligram, less than 1 year. That is the dosage. So you have to remember that and use it properly.
Thank you so much for explaining the dosages and in an easy to remember manner. What is the youngest age at which we can safely use oseltamivir?
I think any age. What this season I have seen one patient at 3 months of age. Honestly, I was not suspecting it. I thought it is because it was having fever, high-grade tachypnea, and I thought it may be a viral RSV. But because of that patient's incidence, and he wanted an answer, I went for multiplex PCR. I got flu, and there I had treated it, and it responded fantastically within 48 hours.
Right.
So
Right.
there is no cutoff, I think, because they have mentioned less than 3 months, the dose is 12 milligram per twice a day. Then 3 months to 6 months, it is 20,
Right.
and 6 months to 11 months, it's say 25 milligrams. So we can use it at any age. Only thing is when you suspect and you confirm the diagnosis.
Okay, thank you so much for giving an all-round view of the disease. So definitely we have to move on to the prevention, the vaccine. Can you very briefly tell us about the vaccine, and then we will move ahead on the vaccination part of it?
So vaccination is a wonderful tool. Along with, you have to have that etiquettes to prevent the airborne transmission. So frequent hand washing, masking, and all that is very important. Now, vaccination, the problem is vaccination has to be given every year. It is annual vaccination because the protection lasts for 6 to 9 months only. That is one reason. Second thing is, whatever vaccines are available, that vaccines we have to make a new vaccination. As we discuss, there is a different antigenic drift is there. So suppose there is an NH and SH, two types of vaccine. So when we talk about influenza vaccine, we should be knowing there are two types of vaccine available. One is inactivated, another is live attenuated. So live attenuated we are not using much, but it mimics the natural infection. It has to be given intranasal. Still it is available. Second thing is, whatever available is inactivated vaccine, and there is a now either quadrivalent or trivalent vaccine. So you have two strains of influenza A and two of influenza B, that makes quadrivalent. And if you have two of influenza A and one, either Yamagata or Victoria. Now it is, that Yamagata is out of question, so Victoria only. So that we use, so trivalent. So these two types of vaccines available, inactivated vaccine. And this vaccine, there is two times in a year. There is a WHO consultative meet, which checks at the what happens in last 6 months, which strains are prevalent in which part of the world. Depending upon, they decide these strain to be included in the upcoming vaccine type. So they have meeting, one in February and another is in September. So February people will give the decision about the southern hemisphere, and September will give northern hemisphere. So when you want a pre-monsoon or monsoon, that is southern hemisphere to be used, and when you use maybe winter coverage, maybe October, November onwards, it's a September hemisphere. So NH to be used. So we have two strains, NH and SH. In India, majority we follow the southern hemisphere vaccine. The thing. So maybe I have called more than what you expected, but you can just cross question again where you want to give importance.
Correct. You have explained regarding the Northern Hemisphere strains and the Southern Hemisphere strains. And as you rightly mentioned, whenever you're vaccinating, you have to use the latest strain vaccine that is available. Now, we know that vaccine is recommended from as early as 6 months of age. So finally, can you tell us, Dr. Chetan, why is it essential that the early years of life definitely need the vaccine protection?
Okay, so now, because earlier we want to target, because the children, they are having less immunity, because that is again, that these children or young children, they are the high risk patients, and that's why we have to give them more proactively. So they are having immunity which is not been against this flu viruses, so we need to vaccinate them. Second thing, they are a biggest source of transmission of the disease. So they spread the disease very easily and faster way to the others surrounding. And others, they may have a pregnant woman, they may have elderly, they may have the people with comorbidity. So this flu virus, they gets, almost, transmitted to others who are having a high risk category. So because of immature immunity, they need to be vaccinated early, because the risk of complication is more in this children, so you need to vaccinate them early. Third thing is, because to prevent the transmission of disease, we have to vaccinate them early. And of course, to prevent the severity of disease in children itself, we need to vaccinate them early. So that's why ACVIP says you give it 6 months to 5 years of age. Before 6 months, it is not to be given. So that is the period where we don't have anything. But 6 months to 5 years, that is the recommendation of ACVIP.
Thank you, Dr. Chetan. I think you have highlighted and emphasized the need for the immunization in the early years, starting from 6 months till 5 years. As you have rightly mentioned, disease burden, transmission, severity of disease, I think these are all major concerns for us. So you have in a nutshell summed up the disease as well as the vaccination part of it. So I think it is absolutely essential that annual vaccination has to be recommended. And having talked about the children and the younger ages, I think we as healthcare workers also must make sure to take the vaccines on an annual basis.
Yes, that is very important. Very important.
Right.
Or at the same time, we are not discussing only in vaccination today, right? So I think we should be very careful. Suppose if you have not been vaccinated, and you should be very watchful for even slightest evidence or suspicion of this flu to you, you start with oseltamivir. I think that will work very fast. So because this time what we have seen is just 4th or 5th dose of oseltamivir, you become afebrile. So that's the beauty of this. It is good, something good about this particular episode.
Correct. So we are finding excellent results to the medication. So I think you have really summed up and given the final word that we should also take care of ourselves. Thank you so much, Dr. Chetan, for this wonderful session describing the disease as well as the preventive aspects of the vaccination against influenza. Thank you so much.
Thank you so much, Dr. Sumitha, for wonderful opportunity. I really enjoyed the discussion, and it was something which was required at this point of time.
Right. Thank you so much.